Next speaker is Elaine Hill, Professor of Public Health Sciences and Economics at the University of Rochester Medical Center, and she'll present updates on COVID-19 pandemic mitigation, community economic and social vulnerability, and opioid use disorder.
Good morning, everyone. I'm very excited to share some updates from our team. I do not have a screen here, so I'm going to be looking around the room, so hopefully I see your faces. This talk is slightly different. The guy is not working. I can't advance. I think I have made things difficult, possibly. Oh, now it's gone. Oh, now it's advancing. I think we're okay. Although I'm not sure why there's a thing on the side.
Okay, well, that's a fixable thing. Thanks. Because all right.
Making things complicated. Okay, so I'm gonna overview 4 different projects. So sorry for the fire hose. A couple years ago, I presented some early results from our efforts to identify policy and economic factors that increased drug overdoses during the pandemic. And I think this is a nice companion with the prior talk. And then we've been really working on trying to quantify just national estimates of opioid use disorder across a long time horizon using CMS claims data. We've been thinking about different pandemic policies. So today I'm going to share some work on continuous Medicaid coverage. And then some of you may have seen our poster last year around accuracy of death data in Medicaid and Medicare claims. And I just wanted everyone to be aware of it because it'll probably end up in some of the metadata and the CDEs and that sort of thing. And so that work is ongoing for those who are interested in working with the National Death Index linked to the claims data. So let's start with the update from our project on the dual epidemics. This project, when I presented a few years ago, only had the first year of the pandemic data, and now we've added through 2022. And so our overall question is trying to understand how the pandemic exacerbated the overdose crisis. And in particular, we're interested in pre-pandemic vulnerability. And here we think about prior communities that experienced high overdose rates as well as high unemployment prior to the onset of the pandemic. And then we are very interested in pre-pandemic and pandemic policies. I do want to note, given the prior talk, that all of the policy variation we're using is at the state level, in case I forget to mention that. So many of you in the room are aware that the overdose crisis continues to get worse. Right now, it's on a downward trend, which is very exciting, but I just want to make the note that it still remains about 20% higher than the pre-pandemic peak, and so it's still very much an ongoing crisis. So we were interested in this variation that existed before the pandemic, which is these communities that were hardest hit by the overdose crisis. And so here you see in red the above median counties, and then in gray the below median counties. So we take this and we interact it with event studies, starting with just looking at trends before we get to the event studies. We see that those counties above median were most affected. We do see an upward trend increase for all counties. This holds for deciles and other quantiles, but for the most part, the above median is where most of the effect is seen. So taking this variation, we then interact it in an event study, and what we find is that these above median, so this pre-pandemic vulnerability counties, experience a 12% increase in drug overdose rates overall. And then when we look at specifically for overdoses for opioids, the increase is 25%. So that's stuff that I had presented just that earlier stage. We wanted to tease out other forms of vulnerability. So as I mentioned, unemployment is something that you might think about. And so we went into this thinking, deaths of despair argument that unemployment could be really important for explaining this. And we thought that there would be much more overlap than what you see here. So I just want to orient you to this figure. So red are counties that are above median for both opioids and unemployment, all measured pre-pandemic. The yellow is the above median opioids only. The pink is above median unemployment only, and then gray is below median for both. So there is substantial overlap in the red, but not complete overlap here. So when we use pre-pandemic above median unemployment for these counties, we see a sort of similar effect for drug overdoses of 15% increase. When we look at opioid overdoses specifically, this effect is a 40% increase. So just brief discussion of this paper, and we do a lot more in the actual manuscript, but we find that pre-pandemic unemployment similarly explains this increase, and it can't be completely explained by the substantial overlap. And in interactions, we do see that the counties with both are the most affected. Interestingly, at least from our perspective, we didn't see similar increases for suicide or alcohol-related deaths. And when we look at state-level pre-pandemic policies interacted with these pre-pandemic vulnerabilities, we really don't see much explanatory relationship, both for policies that were specific to substance use, like day limits and PDMPs, as well as these pandemic mitigation policies that we just heard about. Finally, this is something we didn't have an opportunity to share in the past because we didn't look at it, but now we have been looking at all-cause mortality. We found that those counties with high pre-pandemic unemployment experienced very large all-cause mortality during the pandemic, but that we don't see the same thing for these counties that had pre-pandemic opioid mortality. So we're really interested in understanding that better as we go along in our project. Okay, so try to give you a second to breathe, and then we're gonna pivot to quantifying the national prevalence of opioid use disorder using public health insurance. So here we start with comprehensive national data, 100% Medicare fee-for-service, Medicare Advantage, and Medicaid claims. These data go from 1999 through 2022, and then we are comparing that to what I now know to call NSDUH. I was spelling it out NSDUH. I think that's going to save me some words. So NSDUH, thank you very much. I call it BRFIS too, so I'm going to go with NSDUH. 2002 to 2023 for comparison. And it was already noted that SAMHSA does not want us to compare before 2021. So what we do here is just show you these measures over time in NSDUH to start. And so on the top, we have red, which is any opioid or heroin misuse. This is about 3.5% of the population. And then we allow some difference in terms of how NSDUH is capturing opioid use disorder. So in the bottom in the black is the DSM-4, which was the definition prior to 2020. And then in 2021, they allow for two definitions for DSM-5, with an old and then a new that encompasses some misuse. And so we have some differences in these estimates. So we take this and compare it to what we see overall across all of the claims populations that I mentioned, Medicare, fee-for-service, Advantage, and Medicaid. And we compare this to these rates. We see a 2% rate in 2022 for the claims data, which translates to about 2.62 million beneficiaries over the age of 12. As you can see, this is an estimate that is sort of in between the various definitions within NSDUH. So I'm going to be sharing some stuff focused on Medicaid, so I wanted to show you the same thing, limiting to the Medicaid population. And as you can see, those estimates are a little bit closer in the Medicaid population. We don't show the misuse rate here, and that is higher. And some of the work that I'm going to share with you from NSDUH uses that more broad opioid misuse definition. So I just want to mention that. So this is hot off the presses and something that we plan to dig in more as our project goes on, which is with that national death index that I mentioned, we can look at cause of death. And so if we look at individuals who died of an opioid overdose linked to the claims data, we found that about half of opioid overdose decedents have no history of OUD diagnosis in the claims. And so this is really important when I start to show you limiting to individuals with OUD, take that with a grain of salt, because a good portion of the population that's at risk of mortality will not be featured in those data. So from there, we're really interested in understanding how pandemic policies affect the overdose crisis, as I mentioned. And one of the policies that we have been digging into in the past year has been continuous Medicaid coverage. And we'll be sharing some other work on this. I don't mean to overshadow Anna Kitt's, shine tomorrow, but I'm going to give a little bit of a preview for some of this work. And so, as all of you, I hope, are aware, Family First Coronavirus Response Act suspended eligibility redeterminations. And then after March 31st of 2023, as we now coined it, Medicaid unwinding occurred. And so this continuous coverage ended. Prior work has shown that it didn't quite perfectly eliminate Medicaid churn. So we wanted to understand how this affected populations with OUD. And then specifically, we're digging into unwinding now that we have 2023 data. So before we jump into comparing NSDA to claims, I wanted to just give an understanding of the extension margin, like how much Medicaid happened during the pandemic, which could be separate from continuous coverage. Here on the left, I have full population with no restrictions. On the right, I have the population that's most likely to be on Medicaid, so based upon income and age. And so we see large increases in any Medicaid coverage for those with OUD and those without SUD. Taking conditioning on being on Medicaid at the time of the survey, NSDA asks, were you continuously enrolled in any insurance in the prior 12 months? So it's not a perfect measure of Medicaid continuous coverage. So I just want to take that with a grain of salt on the left. But for the most part, we see similar results between using the claims data for continuous coverage and what we see in NSDA, approximately a 10% increase in continuous coverage for those who have OUD. Next, we were interested in understanding disenrollment rates. And again, these are very similar in magnitude comparing NSDA to Medicaid TAF. And there's some suggestion in both that there's an increase in disenrollment in 2023, which may coincide with this unwinding. So one more hot off the presses diagram from our team. We're really interested, as I said, in unwinding. And so we see in 2020 in the top right, that there was a major drop in monthly disenrollment in the TAF that stays consistent through May of 2023, and then we see an increase in the latter half of 2023. I do want to note that this is preliminary TAF from CMS, and so when we get the final data, we'll be updating this. Okay, so I have like 3 minutes. I just want to make sure that everyone is aware of some of what we've found with respect to accuracy of death data using the National Death Index, or NDI. And so the high-level finding is that when we look at the agreement between the enrollment file and the NDI, we find that while TAF has been improving over time, there's still disagreement about 5 to 10% of the time in TAF years. So if you're using the enrollment files without the NDI, just know that you're not getting the whole picture. When we condition on agreement, though, the agreement for death dates is fairly high starting in 2010. So that's pretty reassuring in terms of if death is accurate, that you have fairly accurate death dates. And so our paper goes into more detail about this, but I just wanted everyone to be aware. Going forward, we're really interested in leveraging the NDI and comparing it to NCHS, which is the national all decedents records, to understand sort of the burden of mortality among beneficiaries with public insurance. And so you can see how that ranges across the states. And so we're digging into this more at cause of death level, population level, and trying to understand, sort of holding enrollment levels similar. Is there sort of overburden by cause for those who are on public insurance? So many next steps, looking at lots of different policies that we weren't able to share today, some of which will be in our posters, and we have 2 other presentations, and then we're working on the subgroups of interest for our project. I do want to thank my team, especially those who are in the room who have been working really hard in the CMS claims data. I couldn't fit everyone on this slide, but we're thrilled to be here, and I want to thank our funders. Thank you so much.